Hello there, it's Luke. Hi. In this final session on anaphylaxis, we're going to look at the drug adrenaline and exactly why it's advocated by the Resus Council as the sort of number one first-line therapy in treating somebody who's having an anaphylactic shock, sort of life-threatening emergency. We're also going to briefly discuss the other drug therapies that you might wish to give to somebody who's had an anaphylactic reaction. So, excuse me, there we go. So, the Resus Council offer this definition that anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitivity reaction. And it's characterized really by three things. One, a sudden onset, rather, and a rapid progression of symptoms, and this can occur over sort of minutes really, and that's what I mean by rapid. That there is a life-threatening compromise of the airway, the breathing, or the circulation, or often a combination of those three things. And these can also, the patient can also experience skin or mucosal changes. So you'll recall from the previous tutorials that there might be sort of an urticarial rash, or more distressing to see angioedema affecting the sort of soft tissues around the eyes, the mouth, and sort of more worryingly into the airway itself. Now, this slide is sort of borrowed from the Resus Council from one of their presentations, but it's actually from a sort of slightly older paper by Pumphrey et al. From 2000, and I've included it really to highlight a couple of things. Now, the first of which is to refer to the fact that anaphylaxis is a very sudden, rapid onset emergency, and if we look along the sort of timings along the sort of x-axis along the bottom here, many of these sort of reactions are occurring within a couple of minutes, 5 minutes, 10 minutes, anything up to sort of half an hour, 45 minutes. We're getting not only reactions, not only symptoms, but actually deaths in this instance. So things can progress very badly, very, very quickly. The second thing to mention is that the route of an allergen entering the body and stimulating the allergic anaphylactic reaction is also quite key. So if you can see there the sort of yellow bars coming up here, within a sort of minute, and certainly within sort of 10 or 20 minutes, you're getting a lot of very severe reactions to injected, so intravenous drugs, many of which unfortunately in this period of time of the study had led to deaths. Similarly, reactions related to foods, whether that be peanuts or whatever you might be allergic to, may be every bit as severe. However, they generally sort of occur over a sort of longer period of time. However, that said, still within a sort of hour, a couple of hours, you can end up in a very serious situation, or worse, the anaphylaxis could be fatal. And the reasons for this, we're going to have a brief recap of these sort of frightening pathophysiological processes. So, histamine causes capillaries, the epithelial cells of capillaries, to contract, and so the gaps between those become larger, and fluid can leak out of the blood vessels, out of the capillaries, and into the sort of tissues surrounding them. And this can have two huge effects. The first of which being airway compromise. So if you've got a lot of edema around we're at the level of the vocal cords here and the sort of epiglottis, it can lead to the airway closing up. Similarly, it can lead to a sort of massive redistribution of fluid from within the circulation itself and into the sort of surrounding tissues, which can lead to a decrease in stroke volume, systemic vascular resistance, and ultimately blood pressure and tissue perfusion. The second very significant histamine-mediated nightmare that can occur is bronchoconstriction. So you'll recall that there is a smooth muscle layer of the sort of smaller kind of distal bronchioles, so the air passages in the lungs, and this can be stimulated by histamine and also by leukotrienes, which are another sort of mediator to contract that smooth muscle layer and constrict and so narrow the airways, reducing the airflow into and out of the lung tissue itself. And thirdly, and very significantly in the context of shock, so the sort of failure to adequately perfuse tissues, is vasodilatation. So this is the relaxation of the smooth muscle within the blood vessels of the systemic circulation in response to binding with histamine. And this causes, again, a big drop off in your systemic vascular resistance, and so that blood volume is spread over a greater area, what we refer to as distributive shock, and also the venous return is diminished, and so your preload is less and your stroke volume is less, and these things combine to drop the blood pressure and dramatically impair tissue perfusion, and in doing so, mean that your cellular metabolism is also impaired. And right at the start of all this is, again, a sort of recap. We've got an allergen, that's pollen, food, drugs, what have you, binding with an antibody, so immunoglobulin E, and that sort of plugs into the receptor on a mast cell, and it's the mast cell that releases the histamine and prostaglandins and leukotrienes and other mediators that are responsible for these effects. So we're going to take a quick look at the Resus Council's algorithm for treating anaphylaxis. And I apologise, it's quite a small slide, but obviously very quickly you do an ABCDE assessment of a patient. You'd look for that acute onset of symptoms, that sort of life-threatening potentially changes in the airway, breathing, circulation, and you may also look for skin or mucosal changes. You call for help, get that patient flat, raise their legs, which is like giving them a sort of fluid bolus or a transfusion of their own blood from the blood stored within their legs. And then the first drug they advocate that you give is adrenaline. Now, why adrenaline? We've gone at some lengths to discuss how a lot of the issues that are caused during an anaphylaxis are histamine mediated. So why do we give adrenaline? Well, adrenaline does a number of things for our body that are very important in this emergency situation. It's an adrenoreceptor agonist, and it covers many of the sort of different types of adrenoreceptors. So firstly, it can stimulate and interact with alpha-1 adrenoreceptors, and they're found primarily in the smooth muscle of your blood vessels. And so whereas histamine relaxes that smooth muscle and causes dilatation and sort of a redistribution of fluid within the sort of circulatory system, adrenaline does the opposite. It forces the smooth muscle to contract and constrict those vessels and hopefully move the blood flow away from the peripheries, away from those sort of capacitant storage vessels, back towards the sort of vital organs, improving the sort of venous return and therefore improving preload and stroke volume. That combination of improved systemic vascular resistance and stroke volume will ultimately mean that your blood pressure is elevated, and if that's adequate enough, then hopefully that encourages tissue perfusion and improved cellular metabolism. Now, the second effect that I want to discuss that adrenaline will give is beta-1 adrenoreceptor agonism. And so there are many beta-1 receptors in the myocardium, so in the heart muscle itself, and the effect it has here is to improve the force of contraction, so improve the contractility, and therefore improve the stroke volume, so the amount of blood that's ejected from the heart on each contraction, and it will also so that effect is all referred to as inotropy, so that improved sort of contractility, and it will also help with chronotropy, by which I mean increase the heart rate. And those two things combined, increasing stroke volume, increasing heart rate, will again improve the blood pressure and hopefully begin to turn around this sort of anaphylactic shock emergency that somebody's experiencing. There's a third effect that adrenaline also has. It will act on the beta 2 adrenal receptors that are found within the smooth muscle of the bronchioles within the lung. So an easy way to remember things is beta 1, one heart, beta 2, two lungs. And so there's these beta 2 adrenal receptors in the smooth muscle of the bronchioles. And again, it will reverse the constriction, and so the reduction of airflow caused by histamine and leukotrienes, and instead it will open up the bronchioles, meaning there's less resistance to airflow, dyspnea or difficulty breathing and anxiety are improved, and most significantly oxygenation will improve for the patient. Now this is a snippet of the Resus Council's Anaphylaxis algorithm, giving you the doses, and you'd be using a 1 in 1,000 concentration of adrenaline intramuscularly, so it can act quickly, and these aren't the sort of patients you're going to faff about trying to get an IV line or a cannula into quickly. You just give the adrenaline into a big muscle and repeat it frequently. It says every 5 minutes here, but you'd be monitoring the response of your patient, especially given this is an emergency situation. Now, I'm going to quickly discuss the various drugs that are used in, sort of advocated by the Resus Council in the treatment of anaphylaxis. So we've spoken at length there about adrenaline and about how it sort of very head-on and very quickly helps you to manage the sort of major changes that occur during an anaphylactic reaction. Chlorphenamine, which is a histamine receptor antagonist, so it will block off those histamine receptors. Remember, histamine is the mediator that's responsible for a lot of the issues that we're facing. However, it won't necessarily reverse anywhere near quick enough a lot of the harm that's being done. That's why we need to give the adrenaline. Similarly, hydrocortisone, which is sort of synthetic cortisol, if you like, is a steroid which will decrease the release of all those inflammatory mediators, histamine, tissue necrosis factor, interleukins, all these things. However, just because it's slowing down the reaction is not necessarily treating the problems that we need to deal with of sort of circulatory collapse and airway compromise. And of course, it's an excellent idea to give a crystalloid food bolus, by which I mean some Hartmann's solution or sodium chloride or whatever you have to hand to try and improve the sort of blood volume, increase the preload, and help that person to sort of get out of a shock state and back towards health. So, in summary, we've repeated that the main issue that we have during anaphylaxis is the immunoglobulin E mediated release of histamine from mast cells, and that this causes vasodilatation, capillary leak, which lead to hypertension, but also to edema within the lungs and the airways. And that adrenaline is by far the best drug to give in this situation because it rapidly treats the vasodilatation and improves myocardial contractility, and also relieves the bronchoconstriction to improve the airflow into and out of the lungs. Okay, that's the end of the session. Thank you very, very much for listening.